Hi, good morning, everybody. Welcome to the Friday Department of Biomedical Informatics and Data Science PowerTalks seminar series. I'm very happy to introduce today's speakers. We have a whole panel of speakers. One was not enough, so we have 5. And informatics is a team sport, and we know that all our work nowadays is collaborative. So I'm just going to give a quick introduction because I know that I've been informed that they will also be introducing themselves. I don't want to cause too much redundancy. Our speakers are Austin Fitz, of the Surveillance Research Program, a postdoctoral fellow at the National Cancer Institute. Thank you for that slide. Nikki Wood, assistant professor of pediatrics at the University of Missouri, Kansas City. Wayne Liang, who is our former faculty member, and we still miss him dearly, assistant professor of pediatrics at Emory University, and associate program director for Children's Healthcare of Atlanta in clinical informatics. David Noyd, assistant professor of pediatrics at the University of Washington, and Elaine Fan, clinical assistant professor of pediatrics, division of pediatric hematology oncology at the University of Kansas, Wichita. And they're presented. I will let them continue the introduction. Take it away.
Great. Well, we're so glad to present to you all, and I'm glad to see so many old friends and also names I recognize. Thank you all for your support. If we can go back to the prior slide, we're happy to be presenting this talk to you today. This is a new version of a NCCR webinar we gave back in July about our team's work on the National Childhood Cancer Registry. Which will be discussing the linking of central cancer registries, electronic health record data, and other data sources to support cancer surveillance and research. And for the next slide, you can see this is a team sport. So who are we speaking to you today? Dr. Wang has already introduced who we are individually. We started off working together as the hemonc.org editorial board, creating a ontology and vocabulary for cancer treatment regimens for pediatrics, and then later worked together as part of the NCI, National Childhood Cancer Registry Cancer Center Data Harmonization Work Group. Our work has been focused on harmonizing all the different data sources to build this data platform to drive research and surveillance. And many of us also serve on the White House Cancer Moonshot CC Direct Standards Task Team to help define data standards for HL7 M code for the transmission of cancer-related data between health systems. And so those are the folks who will be speaking to you today. Next slide. So for our agenda, first we will start off with an NCCR data platform introduction and discussing briefly on data standards. Then we will transition to talking about NCCR data harmonization process. We'll then transition talking about use case of the NCCR for cancer survivorship research. And finally, we'll transition to discussing how this relates to M code and hemonc. And today I'll be serving as the moderator. And so now I would like to turn it over to the second speaker. Next slide, please. Dr. Elaine Fan, who will be speaking on the data platform and pediatric data standards.
Thanks, Wayne, for the introduction. Hi, guys. I'm Elaine Fan. Again, I'm a pediatric hematologist oncologist with an interest in clinical informatics. I'm currently in Wichita, Kansas. So next slide, please. I will begin by describing 2 central cancer registries in the United States. So the first one is the National Cancer Institute Surveillance, Epidemiology, and End Results, known as the NCCR program, which captures data for about half of the US population and contains more detailed information. Its counterpart, which is the Center for Disease Control and Prevention's National Program of Cancer Registries, known as the CDC NPCR, it covers nearly the entire US population, but collects less detailed data. Therefore, one strategy to improve the usability and completeness of cancer registries is to augment them with additional data sources. And this brings us to the next slide. So in terms of, as mentioned earlier, our clinical background is in pediatric oncology. So childhood cancer, unlike adult cancer, is rare, which makes it challenging to collect vital information on a large scale. The National Childhood Cancer Registry, the NCCR, which is part of the Childhood Cancer Data Initiative, CCDI, is envisioned as a connected data infrastructure to enable the sharing of pediatric cancer data from multiple heterogeneous sources. The strategy is to enhance central data registries, such as the SEER and NPCR, as mentioned earlier, by integrating additional data sources where patients are linked across registries to create more robust and reliable data. Next slide, please. Then you might be wondering, what are some of the additional data sources? In addition to the central registries as a foundation, there are electronic health records from NCI-designated cancer centers, the Children's Oncology Group, which conducts clinical trials on childhood cancer, and the Pediatric Photon and Proton Consortium Registry, which contains more of the radiation therapy data. So these data sources cover various domains, including the longitudinal treatment, outcomes, genomics, and more. Next slide, please. And keep going. So your next question might be, how do we access the data within the NCCR? There are currently 3 distinct products available. The first one is known as the NCCR Explorer, as you can see on the screen. It's an interactive web application with open access. It covers about 70% of the US population and provides data on demographics, incidence, survival, and more. Data sources include the SEER and NCCR and the North American Association of Central Cancer Registries, the CINA data. You can go next, Austin. The second one is a SEER stat, which differs from the first one, the NCCR Explorer, as it requires registered access. The SEER stat is a statistical software tool that allows users to perform detailed, customizable analysis of cancer statistics. And lastly, we have an exciting new product on the horizon. It's a cloud-based platform. This platform will include harmonized individual level data from across registries and other sources, such as the electronic health records data from cancer centers mentioned earlier. It will feature multiple tiers of access with the option to download data. My colleague Austin will provide more details about the NCCR data platform shortly. And next slide. Then, so next, let's focus on the role of the data standards within the CCDI data ecosystem. As mentioned earlier, pediatric cancer is rare, and the ability to collect data in an interoperable way is crucial to ensuring completeness, accuracy, and reusability, which are vital for advancing childhood cancer research. To address this, the CCDI aims to establish consistent and interoperable standards for collecting, storing, and sharing pediatric cancer data, facilitate data integration across studies and platforms for streamlined analysis, and develop core pediatric data elements for clinical and research purposes. Next slide, please. As we learned earlier, data standards are essential for ensuring interoperability across the CCDI data ecosystem. Establishing these standards requires a collaborative cross-domain effort. Some of our key partners include the NCI Semantics Infrastructure Team, Pediatric Cancer Data Commons, HEMONC.org, and many others. Next slide, please. Now let's look at 3 core components of the semantics infrastructure. The first one is the NCI thesaurus, NCIT, which is a controlled vocabulary of biomedical concepts, including terms related to disease, anatomy, procedures, and more. The second one is a Cancer Data Standards Registry and Repository, known as a CADSR. It is a structured repository for clinical and research metadata. It provides semantic definitions for data using controlled terms and vocabularies. And the last one is a common data element known as the CDEs. These are the standardized metadata elements used in clinical and research settings. They incorporate terms from the NCIT and describe specific pieces of information consistently. They're stored and managed within the CADSR, and they promote uniform data collection and enhance data comparability and integration. Next slide, please. So for example, on the right side of the screen, I've included a screenshot of the pediatric cancer common data elements from the CADSR website. As of this month, there are currently 437 CDEs covering various clinical and research domains and linked to reference data standards. So now I'll hand over to Austin, who will explain the NCCR data harmonization process.
Thank you, Elaine. I'm really excited to talk about this process that we have because we've been working on this for over a year now to really take data from a new data submission that we have that I'll talk about briefly and harmonize these data elements into a very exciting new product. And so I want to talk about the entire process, start to finish, and our 5-step methodology for how we took this data from these electronic health records and we harmonized it into what we hope to be an exciting final data set to release to users. So we started with 12 cancer centers that we issued a cancer center supplement grant for that submitted electronic health record and other real-world data sources to the National Cancer Institute for augmentation to the National Childhood Cancer Registry. And so our team worked together to identify these common data elements found within the NCI's CADSR software to find elements that matched and harmonized well with the permissible values that were provided for these same data elements submitted by the cancer centers. We then had a process of validation, both with the semantics infrastructure team within the National Cancer Institute, the clinical team of experts, which you are hearing from today, and other shareholders within the Childhood Cancer Data Initiative. The next step is to take those data standards and actually physically harmonize, which we are currently in the process of and awaiting that final data set. And that works through a third-party vendor that is working to harmonize this data from the identified data into a de-identified data set into these harmonized standards. And the final and most important step is to actually release that data to researchers, because what good is all this work if we're not actually giving it to somebody to measure? So all that to say, I'm going to take you through an example, exactly how we went through this process from start to finish. And so, for example, you'll see on the left-hand side, you'll see a set of example permissible values that we received for the transplant type data element from our cancer center submission. So you'll see some common themes. You'll see autologous versus allogenic. You'll see relationship of that donor, and you'll see sort of the HLA match status. Once we identified these 3 components that we found within these permissible values, it allowed us to identify 3 separate common data elements that are all represented within this one data element from our cancer center submissions. So from that point, it's a long and complex journey to actually harmonize these pieces into what you see here. So for example, autologous, anytime we see autologous would be mapped exactly to autologous for the transplant protocol type. So that's simple enough. Something like matched unrelated, we have to do a little bit more work with. So we can tell that it is a biologically unrelated donor who is receiving a allogenic transplant, and there is a match based on the matched permissible value. It gets even more complex when we start taking in items and variables like haploidentical related, where we can definitely tell that this is a biological relative who received an allogenic transplant, but because the definition within NCI thesaurus says that a non-match is also a half match, which would correlate to that haploidentical part, then we are able to accurately convey this information. So what does this look like in the final data set? Well, what we'll have is we'll have 4 columns in the final data set that we release to users. You'll have the 3 standardized columns represented in red, and then you'll actually have that untransformed variable as well, so that anyone who is curious about what the original source value was, they can go back and see, we mapped this original value of syngeneic to these pieces. And so if you're looking exactly for those syngeneic variables, then you can go back to the original source as well and see that data for yourself, which is really exciting, I think. And so what does the submission look like that we received? What was our starting point? So these 12 cancer centers submitted over 6,500 columns representing 25,000 patients across 23 million rows of patient data. That's what we started with. And general statistics that I was able to pull from this, we were able to get about 3.5 billion non-null data points that we had to begin with to harmonize, with an average of 77,000 data points submitted per patient. And the average data completeness was 96%. This will, we're hoping to evaluate this information once we get that final transformed data set in our hands and do some of the validation pieces for it. But at this point, this is our starting point. It's really exciting. So what do these elements that we're going to release actually look like? As you can see here, we have a very broad spectrum of different data domains that we're able to provide in this, with the largest being treatment information, categorizing things like chemotherapy, radiation therapy, transplant information, as well as some enhanced diagnosis and genomic variables that we otherwise were not able to get within the registry information that we were collecting previously, which is really exciting. Here are some examples of those different pieces that we're able to collect and showcase within this final data set, specifically looking at new things that we weren't able to really convey with the original research data that we're getting with the National Childhood Cancer Registries. And what I really want to highlight here is how this is allowing us to really emphasize and augment with long-term data that's happening across the course of a patient's care. Because one things that we really struggle with the registries is we struggle to gather long-term outcomes. So things like complications, recurrence and relapse. And so we're excited to have some of those pieces in this final data set. And lastly, what good is a data set like this if we're not able to actually launch this and release it to researchers to actually use? And so I'm going to briefly talk about our NCCR data platform because it's currently in beta testing right now. And it's a cloud-based environment where people are able and researchers are able to create a custom cohort based on the definitions that they want to investigate using this data. And then once that cohort is created, then they can actually take that data and at the time for the beta testers download that data to analyze themselves. But in the future, we will also have a cloud-based analytical software attached to this for users to use that data in a secure environment. This does have 3 tiers of access. When it does go live, you'll be able to see some of the different studies in an open access tour. So any person who publishes data with this or publishes studies with this data will be able to showcase those in a public manner if you're using this data. But if you get the registered access, then you can go and create your own cohort. Then once you've created your cohort, you'll be able to submit an IRB approval letter from your local IRB, and then we'll give you access to that data in a more restricted IRB approval process. So really exciting work, and we're really happy with what we've put together here, and we're really excited to get this data set into the hands of researchers in the near future, hopefully before the end of this year. So I will now turn it over to my colleague, Dr. David Noyd.
Thank you, Austin. So I think, are we doing my M code use case? Perfect. Sounds good. I wasn't sure if Nikki was going next or not. Well, thanks everybody. So I'm excited to talk to you about some use cases here, specifically highlighting the standardized chemotherapy regimens with the minimum common oncology data elements. And using survivorship as essentially a use case, which is my specific area of focus. So next slide. So M-Code, or the Minimum Common Oncology Data Elements, is an initiative that was initially launched by ASCO, the American Society of Clinical Oncology, in partnership with MITRE Foundation. And it's essentially a FHIR-based core set of common data elements for cancer that is standardized, computable, clinically applicable, and available in every electronic health record for patients with a cancer diagnosis. The overall goal of this work is to create a standard health record for oncology. The primary domains for data elements include patient, disease, treatment, outcomes, genomics, and assessments. such as lab and vital signs throughout treatment. This facilitates standardized information exchange between institutions to help patients and providers drive research in addition to coordination with payers, vendors, and government and regulatory agencies. Since its inception, similar to hemonc.org, MCODE has primarily focused on adult malignancies. However, spurred on by the national efforts to transform the childhood cancer data ecosystem, attention to data elements unique to pediatric oncology complements the harmonization work by NCCR. Next slide. So one of the highlights for this is kind of overlapping with my specific area of interest in survivorship. We know that for late cardiovascular disease, and particularly heart failure, is a major cause of late morbidity and mortality, with a cumulative incidence of nearly 12% among survivors at greatest risk. The data elements needed for this risk calculator include cumulative anthracycline dose, field-specific radiation doses, age of diagnosis, and gender. Each of these data elements are included in NCCR and the CC Direct initiative with MCODE. Such data elements can catalyze the implementation of risk calculators for individual clinical decision support and also population health management. NCCR represents a platform for real-world data to not only implement survivorship-focused tools as a use case, but also validate and drive future research to enhance clinical care and mitigate treatment-associated toxicities. Next slide. Perfect. So this is kind of putting it in context with one highlight of the cardiovascular risk calculator, but most of what we know from a research and evidence standpoint comes from the Child Cancer Survivor Study, which is a cohort of over 25,000 survivors who were initially diagnosed in the 1970s and 80s, with an expansion cohort in the 90s who have been followed longitudinally for the last several decades. Analyses from this cohort have led to development and validation of risk calculators for important late effects such as breast cancer, cardiovascular disease, kidney failure, and ovarian insufficiency. The heterogeneity of pediatric malignancies and the treatment regimens underscore the utility of key data elements to predict late morbidity and mortality of survivors to inform risk-based survivorship-focused care. Another tool that I like to highlight is Passport for Care, which is a web-based platform that maps treatment exposures to the Children's Oncology Group long-term follow-up guidelines to generate survivorship care plans. And both of these tools currently require manual data entry and provide a helpful lens to consider areas of synergy with automatic data extraction in the efforts by MCODE and NCCR. Next slide. Okay. So now I'll talk a little bit more about the specifics for MCODE. Next slide. And specifically, as I mentioned earlier, MCODE historically has mostly been focused on adult malignancies. So part of a partnership has stemmed from this, which is called CC Direct, and this stands for the Child Cancer State Initiatives, Child Cancer Data Integration for Research, Education, Care, and Clinical Trials. This is a White House Cancer Moonshot Initiative and a private-public partnership. The primary goal is to expand MCODE to include data elements specific to childhood cancer. This includes identifying data required for pediatric cancer, comparing with existing FAR resources, prioritizing important data elements, determining data flow requirements, model and align this with other work, and then propose an MCODE update that would include these pediatric-specific data elements. In the context of NCCR, the data elements and workflow within FIRE represents a key area of collaboration. As data are harmonized for NCCR, an envisioned future state would be mapping MCODE data elements to NCCR for more seamless interoperability. Next slide. The iterative process for MCODE, now in its fourth implementation, is guided by specific use cases. Relevant clinical information is then gathered to develop a clinical information inventory to establish a concept model and a logical model. A formal data dictionary based on key information helps to translate and map data elements to develop the FIRE implementation guide, followed by validation of the FIRE implementation guide prior to its release for trial use, early pilots, and other operational research purposes. So this is just an overview of the methodology for that and what we're doing currently with CC Direct for the next iteration for the MCODE update. Next slide. So currently, we're continuing to expand MCODE to include the data elements specific to cancer registries, identifying the data required for pediatric cancer, comparing with existing FIRE resources, prioritizing data, determining data flow requirements, and modeling and aligning other work, and then proposing this MCODE update. Next slide. So this is kind of an overview of the current state right now as we've done the data harmonization work. As Austin described, we had 12 cancer centers submit a large volume of data, which then went through rigorous harmonization methods to identify standardized data elements, validate their interoperability and accuracy, and then transform these data to common standards as part of the National Childhood Cancer Registry, with the goal to release a harmonized data set to researchers later this fall. The intersection of this work with MCODE is paramount to facilitate a more streamlined process moving forward. Patients with cancer treated institutions that have implemented MCODE will allow for HL7 FHIR compatible data transfer directly to NCCR without the time-intensive harmonization effort. This complements the individual patient-level goal of interoperability to improve portability of oncology-specific data across institutions as patients change health systems for treatment, survivorship, and transition to adult care. Next slide. Perfect. And now I'll turn it over to Dr. Wood for talking about hemonc.org.
Hi, everyone. My name is Nikki Wood. I'm a pediatric hematology oncology physician in Kansas City at Children's Mercy Hospital. I do about 50% clinical work and 50% informatics work. So I'm going to talk to you guys a little bit more about hemonc.org, which you have heard mentioned by both Elaine and David, and I can't remember if Austin said the words or not. So I'm going to talk more about that. Go ahead and flip to the next slide for me. But before I go into hemonc, I wanted to talk a little bit about some of the notable challenges that we have with treatment data in the current state. So the majority of harmonized data that we have is treatment data, as Austin just showed us in his pie graph, with over 30% of the harmonized data being treatment. And currently, Central Cancer Registry data, such as that from the CCDI and NCCR that Elaine talked about, lacks detailed treatment information. This is likely because treatment data is complex. Multi-drug chemo regimens are the backbone of routine cancer care and clinical trials in pediatrics, and these regimens are not typically straightforward. They come in a variety of cycle lengths, intervals, and multiple variations or arms in just one given regimen or trial. Another challenge is capturing the actual treatment received by the patient, which might be different from what was the prescribed treatment or what they thought was going to get up front. So I have an illustration of this on the next slide. If you're a practicing peds hemonc provider, this screenshot is likely very familiar to you. These paper-based roadmaps inhibit efficient care, especially when our care occurs at multiple locations. So this is a paper roadmap that I created at our institution. So patients that are on clinical trials through, say, the Children's Oncology Group have roadmaps that look very similar to this. But once those trials get closed, patients are often treated on closed arms of trials that are standard of care, which could be the standard of care for a long, long time, such as osteosarcoma, that has not had a new standard of care in decades. But the supportive care and other things might have changed. And so I create new standardized roadmaps so that there's less filling in that providers have to do. And I'll show you an example of this in just a second. So these roadmaps have a line to document the treatment dose that was prescribed and a line to put the actual dose that was received by the patient on the date that the patient received it. Go ahead and click for me, Austin. As providers start to fill out these paper roadmaps, adjust the doses, make comments, say there was a patient that had toxicity, they make notations, things start to get very, very busy. Go ahead and click. Traditionally, then these paper roadmaps, after the patient receives their therapy, get sent back over to the clinic, and these roadmaps are put into a patient folder or file, which then, click for me, are housed in a file room. It's really efficient. And then click one more time. Alternatively, some institutions have come up with ways to scan and save these on their local network so that people can pull them up in their EHR and they don't have to go digging through files. And some people even make these roadmaps readable and editable, and people can kind of not just see them scanned in, but can edit them and so forth. But in any case, that's at the institutional level. And again, it's not efficient for patient care outside of that institution. So treatment prescribed versus treatment received, which, like I said, can be very different due to dose modifications, might not be evident when using a standard treatment vocabulary. I'm going to discuss a little bit more about HEMONC on the next slide. We need to digitalize this, but we must be aware of the limitations. And in addition to creating a standard treatment vocabulary, we need to think about how to best augment this electronic health record treatment data, because the MAR, the medication administration reconciliation, by itself doesn't tell the complete story. So how do we fix this? And what do we need to do? Ultimately, we need to be able to incorporate that medication administration reconciliation data, the MAR, from the EHR for each patient. That MAR is going to tell you exactly the dose that that patient received, even if it's different from what was the treatment that was prescribed necessarily for that patient, which, like I said before, could be due to a toxicity. In addition, to capture chemotherapy received at home, we need prescription filling data from pharmacies. We need to be able to match chemotherapy combinations in the health record and the MAR to appropriate treatment regimens and names. And so a standardized vocabulary of treatment regimens can really help us, and this is where hemonc.org comes in. Next slide. So here we are, hemonc.org. It's a comprehensive online resource that provides standardized machine-readable vocabularies and detailed information on chemotherapy regimens, including the drug names, combinations that go under specific protocols, the dosages, the schedules. It's free for non-commercial use, and HEMONC aims to improve data consistency and interoperability across the health record and cancer registries, in turn facilitating high-quality research and evidence-based clinical decision-making in oncology. HEMONC's standard vocabulary, also known as its knowledge base, is structured into an ontology. An ontology is a formal representation of knowledge as a set of concepts within a domain and the relationships between those concepts. The ontology is used to model domain knowledge in a structured way that enables data sharing, integration, and analysis by providing a common understanding of what those domains, terms, and their interconnections are. Next slide. Sorry if there's a little bit of overlap on that other one. So this model demonstrates how the HEMONC knowledge base was organized into a digital machine readable format, or ontology. So this model promotes interoperability by linking treatment regimens with standardized vocabularies, clinical contexts, and research evidence. In this ontology, chemotherapy regimen information is standardized for consistent use and analysis. The HEMONC standardized regimen model is incorporated into the Observational Health Data Sciences and Informatics, or ODYSSEY framework, through the Observational Medical Outcomes Partnership, or OMOP's Common Data Model. OMOP is one of the reference data standards that Elaine mentioned earlier and is now part of the NCI Thesaurus. ODYSSEY adopted parts of the HEMONC regimen model as its standard for chemotherapy treatment regimens, enhancing the ability to analyze and share treatment data across the network. The OMOP Common Data Model provides that common framework for transforming and standardizing treatment data from different sources. By using OMOP, ODYSSEY ensures that the treatment data from various health systems can be integrated, analyzed, and compared consistently. Next slide for me. So like I said, an ontology is a computer readable representation of knowledge, and this is that human readable form of that. So this is an example of a pediatric regimen for newly diagnosed Hodgkin's lymphoma on hemonc.org. So there's a standard structure for the regimen name, which is COG AHOD 0031, the components, which include the chemotherapy name, the doses, the routes, and then the references. There are also some semi-structured details that we put in here to provide further clarity regarding cycle durations and length. That way this can be used not only just for polling and interoperability, but also more usability for providers that are using it for the clinical context situations. Next slide. So in summary, cancer registries are light on treatment information. Mapping data from registries such as the National Childhood Cancer Registry to hemonc.org's regimen vocabulary can support ongoing efforts from the National Childhood Cancer Registry as part of the Childhood Cancer Data Initiative. Utilizing a computer chemotherapy a computable chemotherapy regimen, allows for upfront categorization of treatment regimen data at the time of case abstraction. It supports the identification of a likely cancer regimen that a patient received and enables comparative analysis of cancer treatments. Next slide. So I will let Wayne, if you want to do the wrap up for us.
Yes, sounds good. Thank you, Nikki. So I hope we had a chance to present to you the work that we've been doing in developing the NCCR resource. Here are our take-home points. The NCCR National Childhood Cancer Registry enhances existing central cancer registry data with linked and harmonized data from other sources, including healthcare centers, hospitals, cancer centers, administrative data sources, and multiple other sources. This is really important because childhood cancers are rare. And so we want to make the most of every single piece of data that we have on each patient. And so by linking deeper data with existing registry data, it allows us to be able to augment that data set and have more power in making discoveries using real-world data. Data standards, of course, are essential to be allow for interoperability across the CCDI ecosystem. And the NCCR data platform is a new data resource for cancer research. We hope that presenting it here will let informatics investigators be aware of this resource as a potential platform you can use to perform cancer-related data science research. And finally, future direction for our work includes integrating with the MCODE emerging data standard, as well as the Hema.org cancer regimen data standard. With that, I want to thank you for your attention, and we want to open up for any questions there may be from the audience.
I have a quick question. I think you mentioned earlier you're looking at cancer recurrence as part of this data. Is there cancer recurrence data available for these patients from the HR records?
We are getting it. Oh, go ahead. Sorry.
Go ahead, Austin. I was going to clarify the question more, but
go ahead.
Do you mean, John, who has a occurrence, or do you mean a recurrence, like a relapse?
Yeah, so a recurrence. So I have it just ended at the end of last month, a U24 subaward looking at cancer recurrence in UAV patients. And we've been, we had a little poster out in AMIA last year, and we were able to do it not too badly, but the big sort of take home from that was that the structured data was actually really important, at least for the sort of NLP that we were using. So I'm just wondering, if you're getting recurrence, are you getting it from like all the different sources that you're getting it from? How many cases of recurrence do you have in your data set, I guess? I was thinking about, comparing, what we've done at UAB with maybe what you guys have done.
Yeah, that's a great question. So we are getting recurrence data in the final data set. It is not universal from all cancer centers because not all cancer centers provided data in the exact same way or under the same requirements. The other thing to consider with this data set is because this is a pilot study and that patient count of 25,000 unique patients is really only about 2% of the larger NCCR. It's still a very small subset of patients. However, we are excited. At least half of these cancer centers, to my recollection, were providing that recurrence data with a associated recurrence date in its own data element. And so a lot of those are separated in an identifiable way, at least when we are receiving that information.
That's great to hear. And you just when the data was provided, it was basically one recurrence. So if you had multiple recurrence, I know sometimes with hemonc, obviously it's you have refractory cancer and whatnot, but just one recurrence date you were pulling with your data set. Is that right?
We can have multiple in that data set. It's not clear right now how frequent that is, but each recurrence would have its own recurrence ID. So each tumor also is given its own ID in our data set with a tumor marker. So we can also track it that way if we get sort of like recurrent diagnoses later on in life and follow-up, as well as secondary malignancies in a similar way. We're able to kind of collect both, but it's not the most consistent or as consistent as it probably could be.
Thanks. I have another question as well, but I'll let some other people ask stuff.
Also, well, thank you for the great presentation. It shows the challenges of trying to use clinical data, especially in complicated chemotherapy regimens and outcomes. And but just wanted to also point out that there's a lot of Q&A going on in the chat, that a lot of those questions have been posted on the chat and then answered. So, you know, take a look at that for your own edification, and also maybe your question has already been answered that. And feel free to answer questions in the chat, since Wayne is answering them almost instantly. I have a question I probably could put in the chat, but since you know, also we not want to discuss stuff too, is how might gene variants be incorporated into this genetic information, genomic information, as well as how that changes over time. We know that when tumors progress and recur and the patient gets worse, often that's can be associated with progression and different mutations. So I'm wondering how might that fit in here?
I can speak more globally and can give the specifics over to Austin. So we are very interested in integrating genomic data with clinical data. That's part of when we say other data sources. One of the other data sources are genomic data repositories that were generated primarily in the research setting in clinical trials, such as through COG. The idea is, let's identify patients in the who are reported to cancer registries. And you know, half of those patients in pediatrics are treated on clinical trials, half of them are not. Regardless, they're all reported. And then what do we know about these patients? We need to be able to actually identify who these patients are behind the scenes. Not to the researchers don't know who they are, but the data stewards behind the scenes at the NCCR know who they are, and then link them to other data that may be found elsewhere, including EHR data, or if they have contributed samples or have had genomic tests run on them as part of a COG clinical trial, for example, and then link that. And then the challenge then next is, how do we represent that genomic data in such a way that we can link it to the clinical data that's available for researchers in a web-based platform for browsing to answer some of those questions. So definitely something of interest and also very challenging. So we are not the ones who have been defining how we represent those genomic data ourselves. We've been working across other programs and teams at the NCI to make sure that we're all representing genomic data at the same way, so that our system is cross-platform, interoperable across other research databases or research commons type of things within the NCI. And Austin, do you want to speak more specifically to that work of representing genomic data?
Yeah, absolutely. It's a great and very important avenue of data stewardship and harmonization. What we prioritize here, which is in alignment with other childhood cancer data initiative work, is really focusing on that HGVS nomenclature, which we were really happy to see provided by multiple different cancer centers that actually did provide us genomic information. Additionally, to the HGVS nomenclature, we're also getting some things like we're getting the genetic source, whether it's germline or somatic. We're getting alteration effect, alteration type. We're also getting the reported significance from some of these places. But our primary focus has been on ensuring that we can provide that HGVS nomenclature to users and researchers, just so that we can get as detailed of a baseline information on that genomic status as possible. It is dated. We do have an associated date with it. It's unclear now because we haven't finalized the transformation process. How many of those are, genomic variations from both the initial or primary as well as subsequent recurrences, or if that data is we don't have the breadth of data yet to maybe realize that. But hopefully in the future, as we expand this and continue moving forward down this genomics expanded path, that we can see those changes and modifications with this data.
Yeah, thanks for the thorough answer. And Dr. Liang, Wayne, you highlighted that you said half of pediatric cancer patients are on clinical trials, which that really shows how challenging it is. That not only chemotherapy regimens are so complex already, but now you're talking about a lot of people are on experimental regimens, and then often people don't follow protocol for whatever reason. I see that Jim Sabino has had his hand up for a while, so I will let him ask his question.
Yeah, thank you. So first of all, thank you very much for participating in our seminar. We really appreciate your contribution to our intellectual community here, and welcome back, Wayne, however briefly. Really appreciate that. Secondly, I hope Pegar Kanar is okay. It seems like his phone was pointed at the ceiling, and I just hope he isn't like falling on the floor or is okay. If anybody knows or he can tell us he's okay. I always turned off his camera, so I guess he's okay. Third, that was a lot of information, and I may have missed some of it. What technology are you using for maintaining your ontology? And do you use, you listed some of the uses of the ontology, but I started working on ontology, I don't want to say how long ago, and the primary reason I did it was for maintenance of the terminology itself, that I was trying to make sure I had enough knowledge in there to build an intelligent tool that would say, hey, this term looks synonymous with another term, or hey, this term belongs in a class with another term, and that kind of thing. So, or this term seems, ambiguous because it has a lot of meaning, information that seems like it has more than one meaning. So I'm wondering if you're using any of the ontology knowledge for sort of intrinsic introspection of your ontology itself to look for flaws or help with maintenance. So if a drug changes, you know which regimens have to be affected by that drug, that kind of thing.
That's a great question and important with knowledge bases and ontologies and updating of things. I am not aware, and Wayne, if you know more or about whether or not that's ongoing, but on the HEMOC side of things, the back end with the parser and all the things where it's utilizing that ontology, I'm not sure what they have off the top of my head set up for that ongoing maintenance, like you allude to, although that's a great question and I'm curious as well. Wayne, do you know?
I can address some of it. So how ontology connects with this project, the first one will be the CADSR system. And so that's managed centrally by the semantics infrastructure group at NCI, and CADSR is the front end. I do not know if they have a backend tool to help them create the ontology, but CADSR website is how we interact with the ontology to browse it. And so our work is primarily I would say 80% of the time we're actually selecting existing concept from the dictionary, probably greater than 80% of the time. And then there are times when we advise on the updating or the creating of new terms, CDEs, common data elements within the CADSR, based on our usage or kind of application of what exists in there to our system. So we lean heavily on the ontology professionals in NCI for that work, given that we ourselves are not, I would not say that we are, very well informed on how to do that professionally. In terms of the HEMOC.org ontology, the HEMOC.org ontology grew out of a Wikipedia style webpage, and over time developed a standardized style guide. And the ontology is created using a parser, a web parser that then scrapes the website and then generates a vocabulary in the OMOP format. So it is following the OMOP CDM in terms of how it structures that vocabulary. That's the best I can tell you in terms of what tools are being used in that space. In terms of what we're doing internally to harmonize the data, that's ontology work and more harmonization to a standard. And so honestly, a lot of what we do is use a lot of spreadsheets, but to compare across. But then the data is then provided to the data vendor who actually performs the transformations in their backend systems. And I'm not able to comment on what they use. We did investigate using OMOP or Odyssey Athena software. We discovered that platform was probably not the best for our use case because that's primarily designed to map to OMOP Odyssey data standards. And we were primarily trying to map to CADSR as our first go-to to ensure interoperability across the NCI data platform. And so in the future, if we were to then more explicitly map to OMOP or to map to MCode or other data standards, we may need more tools. I wonder, Austin, if you can share more details beyond that.
Yeah. There's a lot of tools in development at the NCI that we are working on, not only to help upkeep, because you mentioned upkeep is a real big portion of this. And I think there was a conversation in the chat as well about upkeep of new data with this as well, and how this changes with future submissions and those kind of things. We are looking at a couple of different avenues, not only within the NCI team, but also CCDI specific, or the Childhood Cancer Data Initiative specific working groups that are trying to leverage whether it's a already established ontology like OMOP and Odyssey, or whether it's creating some machine learning protocols and algorithms that really can leverage these ontologies that are already existing to expand data, or find new portions of data, and really make the most out of the data that we have available. And so that's the kind of things that I think of when jumping into these sort of avenues. But yeah, once again, we don't work too extensively with the ontologies itself, at least from the NCI's perspective within this team. But we are sort of working adjacent with other teams doing really exciting work.
Thank you.
Yeah, thanks. Just highlighting, there's been some great discussions in the chat. For example, talking about how, what happens when we discover something new, and what happens to all our data then? Are you able to update that? And that's a problem in all of informatics, or all of information, is that we're only dealing with what we have right now. And there's always a lag between when we discover new things and when our terminologies and our ontologies and models are able to keep up with that. So, and it's been mentioned before that maintenance is always a challenge. And there was another question about, a lot of questions about specific tools and things. I think those have mostly been answered, but also about the environment. What about exposures and things, and toxins? And we know that pollution, we know those things can contribute to cancer. And it sounds like those are not the big things being addressed right now. Obviously, that's a very, very right area for new development.
I think the key here is that our program is not generating data. We're trying to stitch together, link, and harmonize existing data that's being created on this cohort. So certainly, if someone were to be able to create microbiome data, for example, then we'll be able to link them. That's the strategy we've been taking with various different genomic data that's been generated, but they have in the past been linked together, and therefore the utility of those data sets were limited. That's the key. And of course, with our data set, we can link to things like poverty index, or environmental exposure, things that are more zip code or geographically based exposures. That type of thing we can now do, whereas in the past we wouldn't have been able to without this national data set that's harmonized. So certainly that is an avenue of going forward, but we're not the ones funding research and data generation, if that makes sense. We're stitching together, harmonizing, linking existing data to make it more useful and powerful.
And Wayne, to piggyback off that, I think it's important for us as informaticists and oncologists and clinicians and researchers in this work to really think about, as we move forward, as we learn from the challenges that we've had and what we're trying to piece together and how we're trying to pull all these things and stitch it all together, like you say, what's the best way to do it moving forward? Because, one thing that's challenging that we've come across, and, as we all practice kind of applied clinical informatics, is changing providers' workflow and how they document and how they tell their patient story is really challenging. So for us to come in and say, okay, we need you to start documenting this in this way so that we can capture this information more discreetly, while we can kind of sell it to them that it would be, why it would be better to do. It's very challenging to change their workflows. And while I feel like when I first started getting into informatics, the thought was we need to start documenting in a discrete way. I think now with generative AI, and really, of course, I'm going to open that can of worms with 3 minutes left in the talk. I think there's definitely more advanced ways that we're going to be able to use moving forward without actually changing providers' workflow. I'm definitely 100% a proponent of structured data and standardized data, but how can we do it in a way that we still tell the patient story, where we're still gathering that information to care for the patient, to allow other caretakers and providers in our institution to care for the patient, but also where we might send them and where they might go when they're on vacation, so that that travels with them. And so, you know, sometimes we get so in the weeds thinking about our specific projects, taking a step back and thinking about, you know, what's the best way moving forward? Where do we want this to be in 10, 20 years? Right now, this project is really trying to get that information that's out there and bring it together so we can do research. But what do we need to do moving forward? Do we need to do anything with these large language models? And so kind of more hypothetical, but that's just something I like to think about with all of this work too, is, you know, where are we now? What are the challenges? Where are we going? Where do we want to be? And that could change with another new, you know, informatics tool that comes our way in the future as well.
Yeah, thanks for that. You know, it was brought up the question about patient-reported outcomes, PROs, because we always good to get outcomes, not only say clinical or survivorship. And unfortunately, there's a lot of missing data, but that is something that could be included, maybe more in the clinical trial space. Also, I'm glad you brought up the large language models, because whenever anybody talks about having a big, great data set, there's always, well, how do we make it more accessible by having, you know, interfaces and tools and things? I guess the large language models would be an example of that, or other kinds of AI. So I don't know if either you recommend things to people, or you have your standard formats that helps in itself. I don't know if you have other plans to help bridge the gap between the data and the tools to help people use it, so you don't have to be a technical whiz to be able to use this data. Any thoughts about that?
I have a lot of thoughts, but I don't want to take up the last bit of our time. I mean, in our institution, interestingly, through all of this, I consider myself, you know, newer in the field of informatics for sure, but we're changing our electronic health records. So over the next 18 months, we're going to be building everything on Epic. We're going from Cerner to Epic. And so it's a prime time to look at our workflows, specifically regarding documentation, especially of this discrete data and things from the oncology side that we want to be able to be more streamlined about, not only for data reuse and patient outcomes, but for provider efficiency and really kind of keeping everyone on the same page more quickly. So I'm really thinking about all of this and how to not only train our staff, but what's the best way moving forward, and thinking about those workflows, given that we have this prime opportunity to potentially integrate some of those changes or push for them. But curious to hear what others think in not this situation.
Yeah, well, unfortunately, we're at time. Yeah, I know that you're thinking about all these things, and so I'm confident that in the future that there'll be, you know, next time that, you know, the updates, you'll continue to have expanded functionality, and especially as you get larger and have more experience with the user community. So with that, I think unfortunately we have to end. So I want to really say thank you to all our panels of speakers. It was a really great presentation. I liked how it was integrated, and, you know, I had the clinical and the technical and all the standards, and, you know, informatics, just pure informatics. And you know, continue doing what you're doing, making use of those making use of those nuggets of pediatric cancer data. If you have any questions, you know, we have the contact info for these folks, and you know, hope everybody, you know, has a great weekend, and look forward to seeing you at the next Power Talk. So I don't know if anybody has any final thoughts, comments, questions before we have to wrap it up. But thank you for everybody, and thank you especially everybody for attending and staying till the end.
Thank you.
All right, bye everybody. Thanks again.